It's my great pleasure to introduce our most traveled speaker, I think, of the 3 days, all the way from Korea, and the Samsung Advanced Institute of Technology, Dr. Ogan Gurel.
Good afternoon. Thank you, James. And I wanted to thank the organizers of this fabulous conference, in particular Sharon Hindley. Some of you who have been speaking know her very well. She's been very tireless and dedicated to organizing the conference, and she just gave birth to a baby daughter last week. So alas, she gave birth to this conference, but also to her daughter. So she was a great organizer, and Catherine Richards. And of course, the Welsh government, the Far Institute, and I should say everybody in Wales, thank you very much for the warm hospitality coming all the way from Korea. It truly is a fabulous conference. There's been some great speakers just this morning. And in fact, one of the themes that I wanted to talk about was mentioned by Michael Schrage of MIT, where the content of the audience is more important than the content of the talk. And I'll explain how that fits with my talk. As many of you know, I'm from Samsung, from Korea, and I won't be talking specifically about Samsung. I'll mention a little bit about what we do in healthcare. I have my colleague, Mr. Scott Andrew, who will be giving a breakout session on Thursday morning. We'll be talking a little bit more specifically about what we're doing in digital healthcare. Rather, my purpose in this session, and I very much appreciate your time, and interest, is about how this digital healthcare is changing the paradigm of medicine. And when I'm talking about paradigm of medicine, I'm not just talking about the modern era. I'm talking about medicine as it's been practiced for literally thousands of years. So since the time of Hippocrates, we have certain assumptions, we have certain logic in medicine that digital healthcare, with all the smartphones and tablets and EHR and EMR that we've been seeing, are profoundly changing. And I wanted to explore some of those paradigm shifts. And since we are in the middle of these shifts, I'm not going to advertise them as being a fact. These are really things that we can explore in a wonderful setting, a wonderful conference like this. And I hope that this will be of interest to you. So if we go, this is the front page of this slide, which shows the Prado Museum in Madrid. And I'm going to show some background there that will illustrate some of the main points. And the first slide here is Las Meninas. It's a very famous painting of Velázquez of the royal family. And you might say, where's the royal family? Where the royal family is in the mirror there. And so you can think about whether this royal family is being painted in reflection by Velázquez, or if you, in the audience, are in fact out there as the royal family. And I have this here because Michael Schrage mentioned the content of the audience is more important than the content of the talk. And indeed, this painting is fabulous because it's talking about you being essentially the subject matter of the painting. So it would be great if we can engender a discussion. I don't know how much time we have for questions and so forth, but I'm sure we'll be able to talk during the course of the conference, because this is really about your efforts. And I wanted to lend some thoughts on that. So have you ever been part of a revolution? And I think we are in the midst of a revolution. And would you survive such a revolution? Famous painting by Goya, of course. And of course, even the powerful eventually fall. And technology, we had another theme from the morning, the importance of patience and the importance of people and the importance of human interactions and not being driven by the technology. And sometimes organizations and people follow the technology and they become blinded by that. And then of course, current business models can fool us into not making those transformations necessary that I'll be talking about. So there are 9 paradigm shifts. Obviously, it's just somewhat arbitrary how I organize these things. But there are 9 paradigm shifts that I'd like to explore over the course of the next half hour or so. The first of these is decentralization, going from the hospital to the home. And this is not necessarily very ground-shaking or earth-shaking. Obviously, this has been a trend going on for about 20, 30 years, even longer, certainly in the United States, outpatient shift and so forth. But I wanted to explore how this has been accelerated and the impact on the structure of healthcare, as many of you are familiar. A second paradigm shift, which might be a little bit less familiar, is what I call parallelization. In other words, we have a paradigm in medicine of serial logic. You do a blood test, that blood test determines another blood test. Based on that blood test, you may go to an X-ray, you may go to an MRI, and so on and so forth. There's a very serial logic. And I submit that that is changing with these ubiquitous sensors, not just the wearables, but also the Internet of Things that has been mentioned throughout the day. And so we're getting data all at the same time. And I call that parallelization. And that changes the fundamental logic of medicine, even as we learned in medical school or other health professions. And I wanted to apologize. I'm a physician by background. If I'm referring to doctors, it's not any particular bias. Of course, all health professionals, of course, patients are influenced by these paradigm shifts. So when I say doctors, we're talking really more broadly, of course. So a third paradigm shift is the wellness medical convergence. In other words, the medical side, the wellness side is codified in many aspects of our business, in our regulatory framework, in our legal framework, in our education framework, and that boundary is blurring. So we're going to need new regulatory paradigms to encapsulate wellness measures that impact on disease. So the FDA just adapted their accessories for mobile healthcare, or issued their guidance last week, and they said that these accessories, if they're purely for wellness, they don't need to be regulated. If they have an impact on a disease, then they need to be regulated. And I was very disappointed with that FDA ruling. This is not an official Samsung opinion. I was personally disappointed because they were still trying to separate the wellness and the medical. And if we think about it, if we have a fitness tracker or more sophisticated sensor that's trying to impact on our disease chances, trying to impact on or prevent our disease chances, then essentially that wellness parameter does have a disease impact. It's going to have a medical aspect. So I think that the effort to keep on separating those, I think, is artificial and is one of the reasons why preventative medicine and a lot of these new technologies haven't gotten the traction they have, because they're kept separate from the medical. And we'll talk about this in more detail shortly. Another very interesting paradigm is the shift from explicit to implicit logic. We had a very interesting session on big data this morning. Dr. Üstün from the World Health Organization and others, we had discussion about these issues. Big data, obviously everyone's talking about big data. It's a big running concept, of course. And, but there's some profound changes in the way we think about medical problems and our medical logic. So explicit logic is things like algorithms, anatomy, physiology, cell biology. This protein acts on that receptor, this hormone binds to this receptor, activates this DNA sequence, so on and so forth. You have a soft plaque in the coronary artery, that ruptures, it blocks the coronary, you get less blood to the heart, you get a heart attack, you release enzymes. These are explicit logic, and based on the explicit logic, the doctor will say, well, we have this logic and we give you this medicine. But implicit logic is, well, the doctor says, all this data out there says that we should give you this medicine. What does that mean? And it might be better than the explicit logic. It may be worse than the explicit logic. We don't know. And that's what I mean by the paradigm shift. We need new ways of thinking to accommodate these fundamental, profound shifts. As if that wasn't enough, there's another paradigm shift. It's context-enhanced data, and this relates to the integration of data that we talked about and the parallelization of data. One of the fundamental concepts in medical technology is we need more and more precise data. And that rises up the cost of healthcare. You have to go to the hospital. You have to get the blood pressure with a fancy machine that's the size of this room, that sort of thing. That's going to make it for much more precise measurement. A lot of doctors don't necessarily want the most precise measurement. They want the correct measurement. What do I mean by that? Let's give an example with blood pressure. The well-known problem in managing blood pressure, huge problem, of course, worldwide, is the white coat syndrome. And the patient goes to the clinic once a month or every 2 months, gets the blood pressure, and it's very high. And the next month, because it was high, the patient is nervous, it's even higher, so they are not adjusting the medications. The doctor would like to have a blood pressure measurement in the home, in the context, related to the environment, related to the stress of the patient's life, so that context actually adds more accuracy to data that may not be that precise. In other words, more precise data may not necessarily be better, and I'm not advertising that we need to be lack of precision, but context of the data. So the blood pressure in your everyday life, integrated with environmental information, either from your home or the weather service, integrated with your activity during your life or your activities, is going to be profoundly more accurate, or at least that's the hypothesis, than just purely isolated data that may be precise but not so useful. And then, of course, the shift from episodic to pervasive care. We've seen some discussions about that this morning, where basically information about our health is passively collected, and we're essentially taking care of our health all the time and not just when we go to the clinic or the hospital. Another very interesting concept is that of populations and individuals. So if we look at this concept, it's we have had clinical trials that look at a population under controlled circumstances and apply that to your individual case. But now we're having big data all at once. So population data is coming in, and then, as I mentioned, that's going to influence the decision for a particular individual. And then that individual data is, of course, contributing to population. So we don't have a separation of the population. Department of Epidemiology is not separate from the Department of Family Medicine. That information is coming together. And then another very important aspect is a paradigm shift, is empowering primary care. So there's been a lot of talk over the past 30, 40 years, particularly at the NHS, but we've tried to do this a lot in the United States, of trying to have more primary care. Especially in the United States, NHS has been more successful with that. And of course, there are forces that enable specialty care to be more powerful, whether it be in reimbursement, in influencing the agenda, in driving costs, etc. So specialty care, particularly in the United States and in many other nations, has been primary. I shouldn't use that word, has had primacy. And one of that is that the primary care physician has not had the information that really can compete with what the specialists have. But if you have this digital healthcare enabled data, where the primary care doctor has access to genetic data, of course, to the medical knowledge, and then to this context data and sensors about their patient, they have a much more powerful data set, and essentially they are empowered, as I mentioned. So I think we're going to see a real shift in power back to the primary care doctors, which has been really a holy grail for the past 20, 30 years. And finally, a big paradigm shift. Ever since the time of Hippocrates, we've had a separation between diagnosis, treatment, and prognosis. And we're going to see a fusion, increasing convergence, not just with digital healthcare, but with medical technologies in general, between diagnosis and therapy. So we will have a diagnosis of your blood sugar, and then, of course, an insulin injection at that moment or soon thereafter related to that diagnostic evaluation. And of course, there'll be more sophisticated examples of that. So decentralization. This is a little picture. I'm not going to go through it in detail. It's just a schematic, but you can see that the ultimate in healthcare will be in the very lower left-hand corner will be President Obama taking care of himself in the White House. So we're moving from the hospital with specialists to much more localized care. And we have examples of that. Samsung has done some projects with home care, distributing tablets, smartphones to home health aides, nurses, etc. And so this is just a trend that we're seeing, and that's going to be accelerated, of course, with mobile technologies. That's just by definition. So I go to a lot of seminars, a lot of conferences talking about EMR, EHR, and many of them are in the setting of hospitals. I think we really need to think about EMR and EHR and all that in the setting of what it means to collect that information in the home, because that's where more and more of the bulk of healthcare is going to be delivered. Parallelization. So this is an example of a prototype of our SAMI, which is the wristband under development at Samsung Strategy and Innovation Center in San Jose. Basically, it's meant here to depict you're collecting multiple sensors, multiple parameters all at once. Heart rate, temperature, blood pressure, and this is just a schematic. There's going to be, I think, very importantly, the Internet of Things. I think that's going to be more significant than the wearables. So we'll have environmental data, as I mentioned, activity data, genetic data, all of this coming in parallel. And we still don't understand, I think, how that's going to influence a medical logic. As I mentioned, since several thousand years, we've been thinking in serial terms. The wellness medical convergence. I think this is extremely important. So this is a little article that basically a lot of our IT is still fixed on the medical side. The electronic medical record, as I mentioned, the electronic health record, still fixed and focused on what's happening in the hospital. We're talking about data. I was in the Madrid Health Insurance CEO conference last summer, which is where I visited the Prado and was very impressed by the museum there. And the health insurance executives, and these were top CEOs of private insurance companies worldwide, they were talking about a very interesting concept, non-native data, instead of native data. Native data being the billing data, the claims data, the electronic medical record data that goes to the insurance company. They were more interested in the non-native data. And what was that? That's the fitness data, that's household lifestyle data, that's weight and blood pressure and other behavioral activities that are all collected outside of the electronic medical record. So the insurance companies are very interested, but we don't have the mechanism for that. They were literally aching for that kind of information to help them in their actuarial calculations, in serving their subscribers and so forth. So there's a very strong interest from the insurance side on the wellness data. And then also from governments and the whole paradigm of preventative care. In the United States, certainly, there's been a real resistance to preventative care. Of course, everybody's talking about it. President Obama's talking about it. President Nixon talked about it. And somehow the magic formula for making preventative care has not been achieved yet. And then, of course, with Obamacare, the Affordable Care Act, there's been mandates for certain preventative measures, but those are artificial. And I would submit that the key difficulty is the connection between the wellness data and a medical outcome. If you're walking or you're eating a certain way or you have a certain exercise, what is it going to affect your shoulder for rotator cuff injury? Or what is it going to affect your diabetes risk? You have to make that connection, that prognostic connection, which I'll talk about a little bit later. And so far, as I mentioned, our regulatory mechanisms are industrial structure. Even at Samsung, we have the medical side, we have the wellness side. All of this is fixed, and until we have that convergence, which is happening, I think we'll still have challenges. This is a very interesting concept, implicit versus explicit logic. I'll talk about another aspect, not healthcare, that was very fascinating. they're talking about government by implicit logic rather than explicit logic. What do I mean by that? Well, we all are a nation of laws. We have laws, unwritten ones in England, written ones, a written constitution, I should say, in the United States. It doesn't matter written or unwritten. They're laws, which are explicit proscriptions against doing certain things. Imagine a society where the laws are based on what's happening in the prevailing big data. So you're not supposed to kill somebody because basically that's not good, because that's not good for the society at that moment. That's, of course, an extreme situation. So the point being that rules for living, rules for medicine, being established on the basis of actual empirical data happening at that time. I was driving here with a colleague this morning, and we were using the Google Maps, and the Google Maps was saying this road is very crowded, and we don't have that in Korea. We're very sophisticated in Korea, but we don't use Google Maps. We have our own systems and so forth. So I thought that was quite interesting. And he said, well, it's based on what other people are driving. The data is coming. So there's a red line there because of what the current situation is. You can imagine an explicit logic where there's a red line there based on the historical trend, based on the time of day, based on the width of the road, based on maybe another event happening and some sort of equation that explicitly tells you that it's going to be crowded. But instead, it tells you that it's crowded because that's just the way it is. So imagine medicine being that way. And I think that's a natural conclusion from a lot of this big data. Now, whether that's going to be a balance between explicit and implicit, we don't know. But the whole medical education, the medical clinical trials, all of that needs to accommodate this profound paradigm shift, and I'm not sure if that's been entirely considered. Context-enhanced data. I mentioned the example of the blood pressure. I think this is a real opportunity, and we have to figure out ways in Michael Schrage and others talking about interoperability. Unless we get that interoperability, we're not going to have the context-enhanced data. What's the relationship between someone's allergies and the context that they've had, whether they were on an airplane, what's the pollen count outside, what's the temperature, what's their other genetic data, how do we put all this together? I think the hypothesis is that Michael Schrage was mentioning this, that the value of the data will be greater. That's a hypothesis. But even if that's true, we don't necessarily know how to bring that together. But context-enhanced data is going to be very important. Episodic to pervasive, and populations and individuals. This is the famous Google flu example, which we know has had its challenges, so it's not exactly obviously perfect. But I think this relates to this concept of population data influencing what's happening at the individual level, and individual data, whether you're searching or you have some other interaction, passive information exchange, individual data then feeding into the population data. So they're feeding into each other, happening at the same time, and coming up with insights from that, whether it be an individual therapeutic insight or an epidemiologic insight. They're all the same. It's happening at the same time. Whereas again, previously, we've had epidemiology and individual medical care separate. So empowering primary care, I think, is going to be extremely important. So we need to focus on, and when I mean primary care, not just primary care doctors and GPs, but nurse practitioners and other health professionals that are delivering primary care is going to be an important part of this digital healthcare. And so we have a system that is very much driven by specialists, consultant physicians in the UK terminology. And I'm not saying that we should have a revolution to get rid of consultants, but I think that that has its biases. Several speakers today have talked about the silos between medical departments that interfere with interoperability. And so I think this primacy of the primary care is going to go a long way towards enhancing that interoperability. So a lot of these paradigm shifts obviously interconnected. Diagnostic therapeutic convergence. I want to give a little lay of the land of medical technology. This is kind of a one-page overview. You have at the top surgical technology, so basically some form of localized intervention into the body. Surgical meaning also minimally invasive, not necessarily open surgical. On the left-hand side, you have biopharma, basically drug therapies that are interacting with the body, typically proteins, to influence. So the two on the left, basically surgical and medical, are examples of matter interacting with the body, whether it be a surgeon's hand or a drug. It's a matter-matter interaction. On the right side, we see imaging and IT, and at the bottom, we see some sort of radiation or nanotech influence. And then the overlaps are various technologies. So we're getting more and more convergence, and I would submit that we're moving more and more towards the energy and information side. So again, diagnostic therapeutic convergence being enabled by the actual convergence of medical technologies from the diagnostic and energy on the right to the matter-related interventions on the left. So here's an example. This was announced last year in the New England Journal by a group from the Mass General Hospital and Boston University, so-called bionic pancreas, where you have a glucose sensor that's embedded. So that's a diagnostic piece. It's a sensor. And those are getting more and more non-invasive. They don't need to be embedded as much. We have work at our Samsung Advanced Institute of Technology on non-invasive glucose sensors. And then you have a smartphone that is collecting data from that sensor. And then a implantable insulin pump, which is delivering the therapy. So the smartphone being the link between the diagnosis and the therapy. And as I mentioned, that was presented last year, I think a very exciting result. So I mentioned nearing the conclusion of the presentation how we've gone many ways, substantially away from how medicine was established as early as the time of Hippocrates. So parallelization, implicit versus explicit logic, populations mixing with individuals, all these sorts of things, completely different than the medicine that has defined, quote, modern medicine. But I would also say that in some ways we're going back to Hippocrates' vision. So he wrote, actually, in the beginning of his book, it appears to me a most excellent thing for the physician to cultivate prognosis. So if we have diagnosis, treatment, and prognosis, actually, in Hippocrates' time, prognosis was the most important. You can read through the rest of the quote. He continues the argument. Prognosis was more important. In fact, if you're a patient and a doctor says you have, stage 2 non-small cell lung cancer, with a certain epidermal growth factor receptor or whatever, and the doctor is very self-satisfied and they say, well, at least it's not idiopathic. And they're saying, well, I got the diagnosis. As a patient, what does that mean to you? I mean, do you really care if it's non-small cell or adenocarcinoma? I mean, of course you care, kind of, but you actually care how long will you live? And what does it mean for your activity? Those are the kinds of questions that are very important. So the doctor says, well, maybe the diagnosis is not so important, but I know this certain targeted drug therapy along with chemotherapy, and then we can do this super gamma knife therapy. And again, the doctor is very proud that they have all this therapeutic technology. Again, you don't really care. You care what it means for your life. And I think that this advanced technology has taken us away from Hippocratic medicine by these paradigm shifts that I mentioned. And I don't necessarily mean that's a bad thing, but it's something we need to keep in mind very significantly. But in some ways, it has brought us back to this dream of being able to focus on prognosis, because wonderful medical technologies after the World War II era, penicillin, surgery, all these sorts of things, made it possible to do great diagnosis and treatment, and raised the status of diagnosis and treatment, which of course are not bad, but ultimately we want prognosis. And I think with this big data, and as Dr. Houston mentioned, big data is not going to solve everything, but if we have big data, we have context-associated data, we have a combination of implicit, explicit logic, we have primary care, we have care in the home. All of these things are going to add, and genetic data, et cetera, to this prognostic vision. So we have a couple of examples. Just wanted to go quickly through this. As I mentioned, my colleague Scott Andrew will talk a little bit more in breakout session on Thursday. We had two projects, many projects. There's two examples. One in Denmark with home health care, personal care assistance using tablets. Also with Sutter Health in the United States with, again, the home health care solution, embodying several of the concepts that I've talked about previously. And then more advanced technologies that we're working on include two things. One is the SAMI multimodality database, which is aimed to collect not just health data, but also environmental and Internet of Things data to enable interoperability, context-driven parallelization of data collection. So basically a modality-agnostic database. That's on the left-hand side. And the right-hand side, even more advanced sensors that are being worked on in a wristband form factor called a SIM-band. So I'm nearing the end of my presentation. I'll talk about some key technical issues. One of them, as many of you have mentioned and know fully well, is the ease of use is going to be very critical. Dr. George Crooks was mentioning in his talk about technology being developed for technology's sake and not necessarily about around the patient and their needs and the doctors and their needs. So ease of use is extremely important. And this is something I do at Samsung a lot. We have brilliant engineers and scientists, but they're not doctors. All of us will be patients, of course. But trying to bring that message about ease of use, form factor, user interface, et cetera, is very important. And of course, I think it's been a major reason for a lot of failures in EHR and EMR and other health IT. Privacy and security are very important. Many of you, or several, will be talking about those key issues. So I can't really lend any insights on those in this short period of time, but those are obviously important issues. Low cost. This is sort of a meta paradigm shift, not on a medical logic, but of course, certainly in the United States, we've been more cost is better in healthcare. Obviously, that's changing, not just in the US, but worldwide, and getting more value and lower cost is going to be extremely important. Low power. Nature of most of these healthcare devices is that of passive devices. If you're Facebooking or emailing and your battery's low, guess what? You plug it in or you change the battery. In a Samsung phone, you change it. In another phone, you have to hope for the best. Just a joke. With these healthcare applications, you can't be thinking about that. The battery's dead, the data is gone, and the big data starts to become smaller because it's not working. And in fact, that's one of the very interesting concepts related to what I've been talking about. If you have extended data, parallel data, and supposedly the hypothesis is, and context-driven data, the hypothesis is with multiple data, even though the individual measurements might be less precise, we're going to get better data, we're going to get better insights. But if you have significant gaps because of battery issues, then that's going to be a real problem. So even though it's not directly related to healthcare, battery, low power, electronics are going to be very critical components of successful implementation of digital healthcare. And this is related to the reliability issue. Again, if the battery's out, if you have to plug it back in, etc., and you lose this data, that's going to reduce the reliability. We had a very interesting session this morning on big data where we were talking about global big data. In fact, the data is missing. So big data is actually not so big, and we have to somehow fill in the gaps. So we cannot assume that by big data we mean all the data. There will always be some gaps in the data. So it's very important to minimize those gaps in order to achieve that vision of greater reliability, greater accuracy. Clinical validations are very important. I know that a health insurance company I met back in Madrid, Bupa, as well as the University College London, having a clinical validation around digital healthcare. There are other institutes worldwide. That was just announced last week. So Samsung has a collaboration with UCSF in San Francisco, again for clinical validation of digital healthcare technologies. But I would add that these paradigm shifts that I've talked about have not necessarily been incorporated in these clinical validation. In other words, clinical validation often in the classical model of the randomized clinical trial that characterizes modern medicine, but we have to be thinking about postmodern medicine where those sorts of paradigms may not necessarily apply. Again, as I mentioned, you're the audience, you're what's key to really developing the implications of this. We don't know what those are, but we have to keep this in mind. Data integration, Michael Schrade corrects me, data integration is not so important, it's data interoperability or even use, but I think it's, with all due respect, I'm saying the same thing, so I think that's very important. Single data points are not so important. Those are, we can get those all the time. You go to the doctor, you get your glucose measured, that's not a big deal. Having multiple data points over periods of time and seeing the trends integrated with the population data, that's going to be significant. So the way forward, expand into wellness. I think many people here are related to the NHS, and I know the NHS is very focused on wellness, but this is the message that I gave to, for example, Ministry of Health in Singapore, as well as to the insurance company executives who already know this, but to try to move into the wellness side. It's a message that I think we need to talk with the FDA. I think we really, obviously we don't want to over-regulate, but we need to understand that the wellness side is not going to take off unless it has a medical connection. And likewise, if we focus only on medical and don't emphasize the wellness, then we're not going to reduce the cost and have the better value. I'll give you an example. Everybody talks about chronic disease. I think I have 5 more minutes. Okay, it says, okay, anyway. Everyone talks about chronic disease, and that's obviously increasing, diabetes, heart disease, etc. And there are 2 ways we can improve chronic disease. We can either reduce the morbidity of the actual acute episodes, that's the episodic care, or we can increase the length and quality of the wellness episodes. And I think focusing on the wellness episodes is going to be more effective, but we don't have structure for that. Incorporate wider information streams, use and share data, enhance new ways of medical thinking, and do new ways of medical thinking. Last thing I want to end with, a little bit of art. This is contrapposto. It's a concept in Italian art, as many of you are familiar, combining a rigid side, and the statue of Augustus here, with a more relaxed side. So the idea of justice and fairness. And so we have hard technology, but we must always remember the human side. And there's a word in Korean, I'm sure all of you can read it. It's called 홍익인간, and that's a Korean concept for global benefit to humanity. And it's a very core concept in Korean culture. But I think even though we're doing all these fancy technologies, we need to keep this contrapposto in mind, not just the hard side, but also the soft side. So with that, I thank you again, all the people of Wales, all of you, for this opportunity to share these ideas with you. Thank you very much.